Friends, good afternoon. Welcome to another episode of the Department of Medicine Academic Lunch. We are doing a radiology series now. A couple of days ago, we had neuroradiology. Yesterday, we had abdominal imaging. And today, we have a consultant radiologist, Dr. Subin K. Thomas. He's going to be taking for us just radiographs. And tomorrow, he'll be taking further imaging, detailed imaging of the chest. So, why chest imaging? Well, obviously, chest X-ray is the most commonly ordered radiograph for medicine people. I suspect in all of radiology, it's probably the most commonly ordered test, and it's also the test which is most commonly missed, meaning people miss common findings or misinterpret findings. So we're very grateful to Subin for agreeing to take this class for us. Thank you, Subin. And I once again encourage all the listeners to write down your questions. And during the end of the session, I request Subin to stay back for 5-10 minutes. There'll be a lot of questions on the chat box. I hope he will be able to stay back for a few minutes at the end of the session and answer. Is that okay, Subin?
Yes, sir.
All right. Thank you very much. So I wish you all a happy and enjoyable session. And for those of you who missed this session or who missed the previous sessions, you can go to our website, medicinecmcvellore.com, or our YouTube channel, Department of Medicine CMC Vellore. And the presentations are usually loaded within a week onto the channel for those of you who have missed this. So with that brief introduction, and once again, thank you to Dr. Elizabeth and the team from radiology for agreeing to do the sessions for us. Over to Subin. Thank you, Subin.
Thank you, sir.
Okay.
All right. So, okay, I'll be talking on something which is, I think, very commonly ordered, but quite difficult. In fact, I think as compared to CT, MR, everything, I think chest radiographs are the most difficult ones to interpret. The main problem being that it's a 2D picture that you're going to get. So it's basically a superimposed picture of everything from anterior to posterior that we are seeing. So there are so many signs and so many things that we need to look for, and there are a lot of things that we need to like be careful of. Lot of loopholes which are there with a lot of pitfalls which we can miss. So I hope I'll be able to help with some of those things. So basically my presentation is just divided into two halves. We'll first go over to on how to read a chest x-ray and what all to look for, how to go about it, and the second part we'll just see a few cases, quite simple cases. So maybe while I ask questions, I hope some of you will be able to give some answers. Um, okay, so when a clinician looks at a patient, this is what comes to their mind. We will be trying to think of which system to think of, which all systems are involved. So when we look at something, any image, these are the things that we look at. Um, so we look at water, bone, air, fat, and soft tissue. So there's a reason why this is important in an x-ray, because the difference in density of these tissues is what enables us to see them separately. So if you take an example for this, you can see the bones which are separate. You're able to see my, yeah, so you can see the bones which are separate from the lungs. You can see the trachea which is separate. You can see the soft tissue which is in the heart and the liver. So the difference in density is what helps us to differentiate between these things. So there is a gradation of things that we are seeing on an x-ray. So if you see metals, like for example this marker that is kept, so it's quite bright, that's probably the brightest that you're going to see. Then will be the bone. Then there's water and soft tissue. If you see the gradation, the water and soft tissue are going to have a very similar picture. So if there is a consolidation or anything, it is going to obscure that region which is touching the soft tissue region. Suppose for example there is some consolidation in the left lower lobe, the attenuation of the soft tissue or the consolidation as well as the diaphragm is going to be similar, so we are not going to be able to see the borders. So that is one of those things that we use to differentiate as to locate where the pathology is located. The other things are fat and air. Again, fat is what you will see in the subcutaneous plane here. Fat and air also quite similar, maybe a bit different, I would say. So if you look at a chest x-ray, like bone will look the brightest. Soft tissues can almost look very similar, and air and fat also will look at this same. So there's a gradation that you need to look for. So when you look at a X-ray sub, like now we have online ways to look at the X-ray. We see it digitally, but suppose the patient comes with you with a film in your hand, make sure that there is enough room lighting is less, and you have to see certain assess the X-ray, like the name, age, and what kind of X-ray it is, assess before you start reading the X-ray. So different people have different techniques to go about it. So some people use it from center to periphery. You can just start off with the, it's like what I do is I just start off with the trachea and then see the bronchus, then start seeing the mediastinal structures, the heart, then the hilum, then I'll see the lungs, I'll see the bones, and then see the adjacent soft tissues and the clavicle and the scapula, and then always go to the hidden areas, so which is the apex, the subdiaphragmatic region, the retrocardiac regions, and the cardiophrenic regions. So different people have different way. It's up to you whether you want to go from outside to inside or inside to outside or whichever technique, but master one technique and make sure you follow it in one way so that you don't miss out on things. All right, this is the one I told you, like from midline to periphery, and always don't forget the tubes, and don't miss soft tissues or bony lesions in the chest X-ray. All right. So when you look at bones and mediastinum, I mean, there are different ways you can see the contour and make out. Lungs can sometimes be a problem. So in fact, like there is a way of scanning the lungs. It is a zigzag manner in which we'll go both the sides. And this is the way that you need to look at. Other thing, what you can do is, what I do is I look at the interspaces. So between this rib and this rib, there's this space. So keep looking at these spaces like that from both the sides, like that. If there is any density which is looking different, you'll definitely be able to make out. Suppose there's a nodule or some metastatic deposit which is seen in the lung, you will be able to make out because it will stand in contrast to the rest of the bone, and it will be more helpful rather than just having a glance from top to bottom. All right, so I why I showed this picture is just to show this is the view from anterior. Like if you're looking at the patient from front, and this is how we're going to see the upper lobe, the middle lobe, and the lower lobe. So why this is important is, see, if you see the left side, the lower lobe, the upper lobe actually is seen almost till here, and this is from anterior, and here you can see the middle lobe which is touching the heart on this side. So suppose there's a opacity which is seen in the lower zone, it can still be part of the left upper lobe. So being zone wise doesn't mean that lobe, so zone doesn't equate to presence of lesion within the lobe. So when we describe a chest X-ray, we don't say upper lobe or lower lobe or middle lobe. We say zones. So you can say mid, upper zone, mid zone, and lower zone. And depending on the silhouette sign or which border is being obscured. So if you see a lesion here and you're able to see the border of the heart, that means it could be in the upper lobe and not in the middle lobe. At the same time, if you're seeing a lesion here, the same location, and the heart border is obscured because the right middle lobe is in contact with the right heart border, we will be able to say that, okay, this is located in the right middle lobe. All right. So I'll just go through some normal structures, which I think we should be able to differentiate. Can anybody tell me what 3 is? What does this point to? Any of the PGs? No.
Superior vena cava.
No, actually, this is the ascending aorta. Okay. So that is the ascending aorta. 3. The next one, 4. Oh, chat box. How do I see the chat box at the same time?
Right atrium.
Yeah, that's the right atrium. So SVC. Okay, it's not SVC. It's the right ascending aorta. So this is the ascending aorta contour that you're going to be able to see. This is the right atrial border. That is the right heart border is formed by the right atrium. That is one important thing to remember. And 5.
Aortic knuckle.
Yeah. All right. Arch of aorta. Yeah. Yeah. All right. Okay, that is the right atrium. 5 is the aortic arch or the aortic knuckle, yes, and 6 is the left pulmonary artery. 7, I think we'll all know it's a left ventricle, and 8, 8 is the right pulmonary artery. 7 is the left pulmonary artery. 6 is the left pulmonary artery. 7, I think we'll all know it's a left ventricle, and 8, 8 is the right pulmonary artery. 8 is the left ventricle, and 8, 8 is the left pulmonary artery. 7, I think we'll all know it's a left ventricle, and 8 So if you notice that this is going down like that, so that is the descending aorta. So this is the ascending aortic contour. This is the descending aortic contour. You should be able to trace it down all the way. I think this is, we are not able to see the disc spaces. It's not a advocate chest X-ray, but technically you should be able to trace the descending thoracic aorta along this line. Okay. All right. So, as I told you, you can go from outside to inside or inside to outside. Or there is this another technique that people use, that is the ABCDEFG technique. So, one is to assess the X-ray first, like to see with what position it's taken, inspiration, expiration, then bones, cardia, diaphragm, effusions, look for fissures and fields, great vessels, hilar and mediastinum. I mean, I'm just going to go through just for the sake of going through the lecture. But however, you don't have to technically go through this. This is just to remember that you shouldn't miss any of the structures. You can always go from outside to inside or inside to outside. So we'll just go over each of these things. First is to assess the position. So this is a normal AP film, how I'm sure all of you would have had X-rays before you joined, right? So if you remember, like they'll make you stand and like make you hold your hand by the side and this and tell you to take a deep breath. You should remember, if you remember where the film is and where the X-rays are coming from, it's quite far. It's quite far. The distance between the film that you're going to see in this picture and wherever the X-ray source is quite far. And the other thing to also remember is that it is a posterior anterior view. That means the X-rays are going from posterior to the anterior region. All right. I'm just telling you so that you'll remember when I show you the AP view. All right. So this is a normal PA view where you move this hand outward like that. The reason as to why you move the hand outward is to move the scapula out. So when you rotate the scapula will move away from the lung fields. So normally if you see the AP view, scapula will be sitting right here. Now we are rotating the scapula in such a way that it will rotate out like that. So as to see the lung fields more better. All right. So that is the AP view. Now this one, if you see, can you see the scapula sitting right there in the middle? Okay, this is an AP view. So if you see the distance, see it's much closer. So in fact, if you like suppose you are taking a picture, like, and you're taking from really far away, you're gonna like, and a picture you're gonna come really close. Whatever picture you're taking from really close is gonna go look magnified, right? That is one of the reason as to why the heart can look bigger. So basically the picture is taken from quite a smaller distance. The film to the source distance is quite small as compared to the other one, which is almost 5-6 meters. Then second thing, your hands are by the side. The scapula is going to sit right here. So the scapula will come in view. So that is PA and AP view. Okay, most of the times what you're going to see in OPD is going to be a PA view. Maybe in the ward, they might take an AP view. All right, this is the lateral view. I don't think we take it that much in here, but this is always useful in different in telling as to whether it's in the upper lobe or in the lower lobe. All right, so that is the lateral view. That is how you take the lateral view. All right, so to assess inspiration, inspiration, if you don't make the patient inspire, you can always have like cardiomegaly. You can always have this congestion of these vessels. It can sometimes look like there is bilateral lobe of pneumonia also. So make sure the patient's X-ray is also having adequate inspiration. The inspiration, how you measure is to see the mid-clavicular line and see the anterior rib, anterior seventh rib should be seen above this dome of the diaphragm. Anterior seventh rib should cross the mid-clavicular line above the dome of the diaphragm. Roughly, you don't need to like exactly see this like that. Okay, so this is a suboptimal inspiration. See, the heart is looking a little big, and here you can see some opacities, apparent opacities, which are seen because of suboptimal inspiration. This is a well-inspired image which is seen on the right side. So what about this one? What is the problem with this? Do you think this is okay? This is not okay. It's a good. Will you be able to say anything on this, or will you repeat this, or what do you think is the problem with this? Underpenetrated. Okay, so Okay, so basically there is less X-rays passing through it. So more X-rays that are passing through it, the more you will be able to see, and better you will be able to see. If you have less X-rays, that means the attenuation. The X-ray is going to pass through your body and then reach the film. So if you have less X-rays, which is starting from the starting source, or the strength of the X-ray is not good enough, it's not going to penetrate all the soft tissue. Instead of that, all of them will look more dark. Okay, so you need to have adequate exposure. That means you need to be able to see what you need to see, and it shouldn't be that everything is passing through. If everything passes through, you will not be able to differentiate between structures. So this is a underpenetrated film. Whatever you said is correct. Okay, then third thing that you see is rotation. Rotation is quite simple. You just see the spinous process in the center, draw one line from this side, draw one line from this side. Okay, it should be equidistant. So if this is longer, then that means the patient is rotated to the right side. All right, if this one is longer, that means the patient is rotated to the left side. Okay, I'm not going to be explaining how that happens. So roughly you can say full inspiration should be at the level of the 8 to 10 posterior rib or 5 to 6 anterior rib. For penetration, you have to be able to see the thoracic disc spaces clearly. Through the heart, you should be able to see the disc spaces. All right. So, but you cannot really always assess a spine on a chest X-ray. All right, you might be able to see some lesions. Sometimes you might be able to see like compression of the vertebral body and all, but you are not technically, you're not X-ray is not good enough to assess the spine and rotation, whatever I told you before. So all right, so that was about assessing the X-ray. Then about bones and soft tissues. So can anybody see what is wrong with this? I hope this is problem. If you see, there is this opacity, a hazy opacity which is seen on the right side. If you see right hemidiaphragm a bit higher, which is normal. So we are talking about bones and soft tissue. So if you trace, can you trace these ribs? Can you trace these ribs? There's some problem here. Rib fracture. Yes, that's a rib fracture. All right, good. So that is the rib fracture. So the important point about rib fractures is that you should be able to trace the cortex. So that line that you're seeing here, what I'm showing you, see here again, that line, that is the cortex. Again, clavicle also. Just follow this cortex like that. So, so that you don't miss any of these things. Even if you trace this also, you might be able to pick up probably a rib notching and all. If you trace up the line, you'll be able to see the notch properly. So make sure you trace the cortex of every rib so that you don't miss lesions. Sometimes a rib lesion might be there, you might be starkly missing it. Sometimes there will be a lesion which is sitting here and might be eroding onto the left first rib or the second rib. So make sure you trace the cortex on each side. This one, do you have any idea what this could be? All right, so there is an opacity. I'll just say what it could be. There is an opacity which is seen. Okay. So do you think it's in the lung, or could it be in the lung? Anybody? Subcutaneous. Why do you think, Yusuf, it's subcutaneous? Any reason? Okay, you needn't say subcutaneous. Okay, it's essentially not in the lung. That means it's extra. So extra pulmonary or extra pleural lesion. So why it is because if it is the lesion inside the lung, two borders. All right. So here you can see this border. Here you can see this border. Here you can see this border. Here you're not able to see the border. So basically, this is the border from which it is arising from. All right. So this is what's the lesion. If you can see, that is the medial aspect is from where this medial aspect is from where it is arising from. And these borders you are able to see because there is air all around it. So air is going to be, the atmospheric air is there. with which we are able to make out the difference between the soft tissue and the border of this lesion. Okay, you can't see the pointer now. Just hold on 1 second. Is it better now? Which image? This image? Is it? Is it coming? Is it coming? Share. Yes. Okay. Okay. Can you see the pointer also? Ah, you can see the pointer. Yeah. All right. So as I showed you before, as I told before, see, atmospheric air is around this lesion. So this border will be seen. This border will be seen. And this is from where it's arising. So we're not able to see this border. All right. Yeah. All right. So that is a subcutaneous lesion. So bones, just because there is one lesion inside doesn't mean that it could be in the lung. All right. Only, of course, you'll be able to see the lesion directly on the patient. Anyways. So next is about cardia. All right. So cardia just doesn't mean the heart. Okay. It also means a lot more things. This, as I showed you before, is the what aortic knuckle. Next one. So these are all small regions which you need to see. Okay. So that's the aortic arch. That's the pulmonary trunk region. Descending pulmonary arteries will be going on both sides. SVC, as you were, someone was saying SVC in the previous one, SVC is seen quite higher up and it will actually drain into the right atrium, right? So SVC's border will be seen quite high. The whole of the right heart border will be formed by the right atrium, and most of the left heart border is formed by the left ventricle. All right. Okay. So cardiomegaly. So how do you assess cardiomegaly? I think that is very, very important. So you draw a line from one end of the heart to the other end of the heart. Draw another line from the inner wall of the chest to the inner wall of this chest. Okay. So intrathoracic diameter, cardiac diameter. So suppose there is a wait. Let me suppose in this X-ray, how will you measure the cardiomegaly? Can you draw a line like this? Can you draw a line like this? You cannot. So what you do is you draw a line in the midline. Okay, draw one line towards this side. From the midline again, draw one line towards this side and add together. Okay, you cannot draw one line like this and decide that this is cardiomegaly. I mean, to measure the cardiac diameter. So you have to measure from the maximum lateral diameters. All right. All right. Okay, so that was about cardia. Then move on to diaphragm. Diaphragm is a very common place where people miss things. Okay, especially in the retrodiaphragmatic region. In fact, actually, if you see like when you see the CT, you will be able to make out like that the lung actually has more of a portion which is seen. If you remember your old anatomy or pathology specimen of the lung, if you remember that there is a tongue-like thing which comes posteriorly. Okay, so the lung has a lot of part which is behind the diaphragm. The lower lobe especially has a lot part which is behind the diaphragm. So that part of the lung is going to be seen at this point. All right, so that's the retrodiaphragmatic region. That's a common place where you miss things. And second thing is this one. This is also very commonly missed. This is what? Air under the diaphragm. Okay, so that's air under the diaphragm. All right, so then about effusions. Effusions are fairly simple. Okay, you just look at the CP angle and see if it is curving upwards. If it's curving upwards, it's more likely to be effusion because of the Ellis curve. So that this is bilateral pleural effusion. Do you know why this has bilateral pleural effusion? Can anybody like figure out why the patient has a bilateral pleural effusion? Anything else that you're able to see? Congestive cardiac failure. Why? Sternal sutures. Good, good. That's a good pickup. Okay. So this patient has had one surgery. Okay. And post-surgery, this is just some post-surgical some effusion which is just bilaterally seen. Okay, sternal sutures, good pickup. All right, very good pickup. Good. All right. Okay, So then about fissures. Okay, so fissures, you won't be able to see all the fissures. All right, you'll be able to see this right major minor fissure which is sitting like this. The other major fissures are situated in this angle. All right, so just to note that according to this picture, if you see, this is the right middle lobe. So if there is a consolidation here, it is going to be touching this border. All right, so the border between the heart, right heart border, or the right atrium, and the lung is going to be lost. Okay, that is what you see if you have a problem in this part. Suppose you have a problem here. Okay, the border between the diaphragm and the lung will be lost. You won't be able to see this much part of the diaphragm. You won't be able to see. Right. Okay, this is just go ahead. Okay, so this is just to show the upper, mid, and the lower zones. All right, we'll just go forward. All right, this is a fissure that I told you. See, this is the middle fissure, the minor fissure on the right side. See, you can see this small dilatation. This is minimal fluid within the fissure. All right, so when you see, look at the lung fields, there are a lot of things to look for. You can have consolidations, you can have nodules, there can be interstitial opacities, there can be mass, or there can be atelectasis. There are different ways to look at all these. Consolidation, I'm sure you will all know, I guess, because it's what you've seen in pneumonia. So the characteristic finding is definitely the air bronchogram, which is seen. So this is in the right upper lobe. Okay, you can see these small loosened lines which are seen in between, very ill-defined thing. So this is a right upper lobe pneumonia. All right, this one, what border is not seen? The right heart border is not seen. So because the right heart border is not seen, we know that this is from the middle lobe. This is the right middle lobe consolidation. All right. Okay, these are these are just images to show, like when you say reticular and nodular. Reticular technically means, if you can see these net-like things, can you see these small lines? Okay, whenever you see X-rays, just for you to like know, like you'll be seeing on your smaller monitors in the OPD, just make sure you zoom it a bit and see, like sometimes when you zoom it, you might be able to see these lines. Sometimes there'll be tiny nodules. Like a lot of people miss these kind of nodular opacities, because sometimes when you see in your smaller monitors, because the resolution is not that great, you will easily miss these nodules. So these are the nodular appearance and these are the reticular appearance. When you have both, we just say reticular nodular appearance. So it just means that it's an interstitial pattern of involvement. All right, so atelectasis, it will look very similar, like it will look dense, but what you're going to look for is volume loss. Right, you can either see fissure displacement, like for example in the right upper lobe collapse here, you can see like middle minor fissure is going to sit like that, it's going to go up like that. So that is the minor fissure which is moving up, and that is what fissure displacement is there. So this is atelectasis along this side. Other thing is to look at mediastinal difference. This is really gross. You can see the whole mediastinum and trachea, everything is shifted to the right side. All right. Next thing is to look at great vessels. Great vessels is basically the aorta and the pulmonary artery. This is the descending pulmonary artery on both sides. So you'll be able to measure, like see whether this is big or small. And you can also see the branches which are going up, the superior pulmonary venous branches also you'll be able to see. So if you note that in this X-ray, you can see more of the vessels are seen in the lower lobe and less vessels are seen in the upper lobe. That is normal because you're going to take the X-ray in a standing position. So because of gravity, the blood will just settle down more, and the vessels which are seen inferiorly are going to be more prominent than the vessels which are seen superiorly. All right. If it becomes reversed, okay, we'll come to that. Okay. Okay, so this is about hilum. So when you say hilum, it just doesn't mean like this region. It has a specific definition. So the hilar point or the hilar angle is actually formed by the descending pulmonary artery and the superior pulmonary vein. The superior pulmonary veins, there are four veins. Normally, there are four veins. Two will come from the superior aspect. Two will come from the inferior aspect. The two of the superior veins will come and join at this point. So superior pulmonary venous trunk and the descending pulmonary artery, these both have one angle at which they join. So that is the hilar point. So the right hilum is usually at this lower point, and left hilum is usually a bit higher. So the right hilum can be pulled up. Suppose you have a right upper lobe collapse, then everything gets pulled up because the fissure is actually attached to the hilum at the end towards towards this point it's attached, so it will pull the hilum up like that. So you will get, along with the elevation of this diaphragm, which may be seen, which is called a juxtaphrenic sign, you can also have elevation of the right hilum. Okay. Okay, this one is just to show you the right pulmonary artery and the descending pulmonary vein. So right ventricle is not something we usually will be able to assess in a normal X-ray, unless otherwise it's enlarged, because it's sitting right in the center. The right atrium, left ventricle, and the left ventricle, left atrium, we'll be able to see more often. All right. So this one, um, this is a lesion which is seen in the mediastinum. All right. So why I'm saying it's within the mediastinum, because you can see the heart borders through it. Okay, and you can see the hilum. Can you see this trachea and these hilar vessels and everything? It is going through. It's in the paratracheal. It's somewhere in the anterior mediastinum. You can see the aortic knuckle through this. So the aortic knuckle, if you remember the CT in cross section, the angle, the posterior descending aorta is formed is at the posterior half of the posterior mediastinum, or the posterior mediastinum. So if you are able to see the border of this, that means lung is covering this region. There is no mass covering this region. So this is the anterior mediastinal mass. All right. Okay, what is wrong in this? Can anybody note and tell me what is wrong with this? You can like just type it in the chat box. Normal, X-ray. So are you like going from center to periphery? So I'll just go from center to periphery. So I'm going to see this trachea, which is like centrally located. Some mild deviation of the right sided trachea. Pneumo mediastinum, no. So some right mild prominent right okay. Okay, one of you has got the answer correctly. Okay, so the trachea is normally shifted a bit to the right side. That is normal, right? A bit of shift of the trachea to the right side is normal. Okay, so trachea is okay. If you see the cardiac contour, see, you can see the nice contour of the whole cardia. You can see beautifully here the right atrial border. Again, you can see. Can you see the ascending thoracic aorta here? It's nicely covered, and this is the descending thoracic aorta, again nicely covered. So I finished the hilum. I finished the trachea, the mediastinum, the vessels. The pulmonary arteries are also normal in size. Both sides, the hilums, you see the right hilum is lower, left hilum is little higher. And then I'm seeing the lung fields. I'll move, do this scanning technique like this. Okay, again, do the scanning technique like this. See the in between spaces. And I'm counting the ribs, 1, 2, 3, 4. This is how we look at X-rays. Okay, I'm just showing you. I mean, somebody has already got the diagnosis. I'm just showing you how we look at it. So this is the ribs. You're going to count the ribs and see both the. This is the posterior half. This is the anterior half. So see, these are the anterior ribs. See these ones. What I'm showing you is the anterior ribs. Right. Then there's a breast shadow. You need to see both sides. Then important points which you can miss in a chest X-ray is apex. Okay, retrocardiac regions, retrodiaphragmatic regions, CP angles. Okay, then soft tissues and bones. I looked at the bones. Scapula is here, scapula is here. This part, something is missing. Okay, Apurva has got it correctly. Missing clavicles. Okay, bilateral missing clavicles. So this is got stuck. Yeah. So yeah, I think it's more. Yeah. So that is cleidocranial dysostosis. Yeah, you're right. Cleidocranial dysplasia. Okay. What is this abnormality? I think it's quite very simple. This is what we show the MBBS students. Where do you think is the problem? Is it on the left side or the right side? Do you think the left side is having some problem here? Looking quite dense here. Yes. Okay, Ruth and Rahul, both of you are correct. It's a tension pneumothorax. So why do you say tension? So like a lot of people, when I've shown this picture, have said that there is some consolidation on this side and this lung is abnormal. No, what you need to look for when you like look at the lung is, okay, what are these small things? These are all vessels. Okay, make sure you look for vessels in the lung. Lung means will have vessels. Just plain air, no vessels. All right, this is just plain air. Okay, no vessels, and this line that you're seeing is actually the compressed lung. The lung is completely compressed towards under. It is just squished, and the whole mediastinum is shifted to the opposite side. See, the heart is like fully shifted to this side. Trachea, everything is shifted to this side. Okay, so this is a tension pneumothorax. What will you do next? He will call you guys, but anyways, you have to put in a chest tube immediately. That's all. This is a tension pneumothorax. This one, again, fairly simple. This one, we the faster we go through this, the more cases you'll be able to see. All right. Okay, I'll just continue. Okay, good. Hydropneumothorax. Why? Because there is a level. Okay, so there is water which is sitting there. All right, and there is air as well. Why? Because just if there is just plain water, it's going to form that curve. If you remember, it will be curved a bit. Okay, if you have air, the air will settle on top and the water will be seen below it. Okay, I'm just saying water, it just means fluid. All right, so this is just to show, see how much of fluid is there. See, it's going from anterior to posterior half. All right, so that's a hydropneumothorax, and this is the normal lung lining, lateral wall lining that you're seeing on this side. All right, that's a hydropneumothorax. All right, okay, that's a pleural line. This one, yes, tell me the diagnosis and where it is. Right middle zone consolidation, very simple. Okay, right heart border is not seen, diaphragm border is seen, right mid zone consolidation, very good. All right, this is the right mid zone I showed you before. I think it's quite easy. Okay, so this sign that we called, I've been telling about this sign for quite some time about the borders. Okay, this is called by silhouette sign. Okay, this is very important when you look at chest x-rays. Okay, so basically whichever border which is not seen due to whatever disease which is there in that region, that sign is called as silhouette sign. Okay, it's called loss of silhouette. All right, this one, simple again. Which side is that? It's right upper lobe. You can see the right heart border through it. Here also you can see all these opacities. No, right upper. Yes. Yeah, not mid zone, right upper zone. This one. Okay, I've put the lateral X-ray to show something. So if you see here, you can see the right heart border like very properly. So that means the mid lobe is normal and is sitting there at this region, and the diaphragmatic border is not seen. That means that this is in the lower lobe and not in the middle lobe. And the lateral X-ray is going to confirm that, because if you remember the X-ray lateral view that I showed you, the lower lobe is going to, yeah, D spine sign. Yes. So basically there is something called spine sign. So if you look at the lateral X-ray, when you come from superior to inferior, the density should keep reducing. All right. If the density is increasing, that means there is some abnormality. So if it is just a lateral X-ray, you won't be able to say which side it is. It can be either on the right or the left, but you have this AP view or the PA view to say it's on the right side. All right. So this is a lower lobe, right lower lobe consolidation. Okay. All right. So that's a spine sign. All right. This one, a little tricky one. Okay. Right mid zone, right heart border is seen, not seen. All right, but it looks a little bit more than, like, just the right mid zone. No, this is actually right upper and mid lobe. Okay, so you can have both. Okay, it's a right middle lobe and right upper lobe consolidation, both together. Okay. So it might be difficult to say sometimes, like on X-ray, like where exactly it is. You might be able to say like mid zone is involved, but whether upper zone also is involved might be difficult to say on this. Okay, this one, I already showed something very similar to this earlier. Okay, there's an obliteration of the retrosternal clear space. Yes, elevation of the right hilum. Okay, I think the arrows are pointing a bit off, but the fissure is also like shifted up. Okay, that's a right upper lobe collapse. So a right upper lobe, you'll see this wedge shape, like triangular kind of opacity. It will elevate the right hilum. I told you right hilum is lower. Trachea can be deviated to this side because there is volume loss on that side. Okay, and in the lateral X-ray, you'll be able to see the retrosternal clear space, and there will be just juxtaphrenic peak signs, not very apparent in this, but you will see one triangle kind of thing, small peak kind of thing in the diaphragm on that side. All right. Okay. Okay. This is okay. I already showed you the answer, I think. Okay. There are these so many signs in radiology already. This is probably something you shouldn't miss, like ever, because every case of this specific pathology will look exactly like this on on a peer view. Okay, I will just tell what this is. So if you see, you can see this. Are you comparing this side and this side? You can see there is more. It's more dense on this side. So there is this veil-like opacity, a veil-like opacity which is seen. Left bronchus obstruction. Okay, okay. I'll just tell you what this is. So this is, there's this veil-like opacity. You can see this side is more dense than this side, right? Okay, there is this veil-like opacity, and you can see one loosened line which is along this aortic knuckle on this side. Okay, this is a specific sign. Okay, okay, it's called Seashell sign. All right, Seashell sign. Yes, yes. Okay, so that is basically like I told you, like the aortic knuckle, like when there is a left upper lobe collapse, what happens is that the left lower lobe gets hyperinflated, right? And it separates the arch from the medial margin of the collapsed lobe. Okay, normally that lobe will be in touch with it, but however it will expand so much that it will just sit over the aortic knuckle like that. And because the left lower lobe is like hyperinflated and sitting over it, you will be able to see this extra bit of lucency here. I don't think I have a CT. Yeah, there I have a CT image. See, this is how you will look like. This is the collapsed left upper lobe. Okay, this is in lung window. This is the lung window that in which we see for lung. Okay, this is the left lower lobe which is hyper expanded, and the superior segment of this left lower lobe is sitting between the arch and the collapsed lobe. So this bit of air is what you are able to, why you are able to see this line. So that's called Seashell sign. All right. This one again simple. This is something you shouldn't miss. I told you there are review areas. So apex, retrodiaphragmatic, retrocardiac regions. Yes, this is, I don't know if it's called sail sign in this, but anyway, yeah, it looks like a sail. This is the left lower lobe collapse. There are so many sail signs actually. Anyway, this is the left lower lobe collapse. You will see this triangular opacity, which is seen behind the heart. All right. So make sure, like when you see the heart, like when you're seeing the X-ray, there shouldn't be, it should be very uniform. Whatever you're seeing behind the heart should be very, very, very uniform. You shouldn't be having any other opacities other than whatever is because of the heart, right? And you should be able to see this border. Okay, up to the to some level you should be able to see this border. Okay. You know why the right diaphragm is why is the right diaphragm higher than the left? You can talk or you can like type. I don't know, I think typing is taking time. Hard pushes, yes, actually, like yeah. I used to think that it's because of the liver. Actually it's a heart. No, it's not the liver, Graham. That's the thing, I used to think that too, but it's the heart. Actually the heart is sitting on the diaphragm. Okay, so that heart is sitting on the diaphragm and it's pushing the left hemidiaphragm down. Okay, so that's why the right hemidiaphragm is higher than the left. All right, all right. Okay, okay, left time. Okay, we don't need to go through. Okay, this one, who's going to pick up this? Which border is lost here? I've actually pointed out with the arrow. We need to go faster. Huh? So I will just continue. No, it's not a right middle lobe collapse. Okay. So if you see this, this is a This is Pectus excavatum. Okay, it can mimic a right middle lobe collapse. Okay, so because the pectus, actually what happens is the sternum will just push it like that, and the right middle lobe will move away, and the right middle lobe is not going to be, the right heart border is not going to be able to, you will not be able to see the right heart border because the right middle lobe is pushed away from it. Okay, because of the pec step. Maybe I can, maybe if I could show you, maybe tomorrow I can show you the axial CT images, you will understand it better. So this is one of the like pitfalls. Don't miss this for, don't say this is a right middle of collapse or some consolidation and all. Okay, this one, very very simple one. Okay, this is miliary tuberculosis, very simple. Okay, so let's see, it looks like miliary tuberculosis. Okay, we just go quickly to heart, some of the hard things. Okay, important things like mainly it's pulmonary edema, MS, and I think congenital anomalies, maybe adult congenital anomalies may be important. Important thing that you shouldn't be missing is a right sided aortic arch or a coarctation. All right, and an aneurysm. This one, edema, yes. Okay, okay, just cardiac failure, edema is there, yes, bat wing sign, very good. So you can see the heart is enlarged and there are these opacities here which are seen in the perihilar region. Okay, bat wing sign. Suppose you were seeing opacities everywhere, not just here, opacities very similar to this, opacities everywhere, but the heart was small, what will you think of? ARDS, yes. So that's the difference between ARDS and pulmonary edema. In ARDS, the heart is going to look this small, normal in size, while in pulmonary edema, it's going to get enlarged in size. All right. Okay. That's pulmonary edema. So pulmonary edema has these. There's a reason as to why we see all these things. So like first of all, I told you that because of gravity, the lower lobe vessels are going to get larger than the upper lobe vessels. So in pulmonary edema, because there's so much of tension, the upper lobe vessels also become prominent. So there is something called cephalization. It's called cephalization of the vessels. So the upper lobe vessels become as prominent or more prominent as the lower lobe vessels. And in the other next stages, there'll be like fluid in the interstitium, that is interstitial edema. When you have interstitial edema, you will find these curly B lines and you can have these effusions and all. The next stage will be alveolar edema, where you will see these opacities which will be seen in both sides. Okay, that's frank pulmonary edema. Okay, and just this is just curly B lines, those basal lower on basal aspect of the lungs, linear lines like this, and these are the curly A lines which will have this kind of orientation. All right, this is okay. This the thing, significant thing is it will reduce after some time. This one, stark thing is that heart is enlarged. Okay, but what do you think is the cause for this cardiomegaly? Pericardial effusion. Okay, anything else that you're thinking of? Okay, you're giving me differentials now. Okay. Okay, is it another diagnosis or a differential? Okay, so basically it's MS. Okay, okay. So if you can see, there is, can you see this line which is going like that? Okay, and this is the right atrial border. Okay, so there is one more line which is seen here. Okay, there is right atrial border, and then this is very stark. See, there is significant widening of the carinal angle. All right, the left atrium gets dilated and let push the carina like that to the sides, and that will produce this widening of the carina and also produce this double heart shadow. All right, that is a mitral stenosis. All right, that's the double heart shadow, and that is the widening of the carinal angle. And this is something, this again, we have a lot of signs. So this is called the third Mughal sign. All right, so the aorta, the pulmonary artery, and the dilated left atrium will produce the third Mughal is actually in the Mughal is these snow, these mounds which are seen. So this is called Mughals. So it's called the third Mughal. It's a third Mughal sign. Okay, this is just VSD. Okay, I just wanted to show you there's this pulmonary plethora which is seen because of increased blood flow into the pulmonary vessels. All right, this one, what does it look like? Anybody? Is it normal, abnormal? Okay, this I'm sure you wouldn't have picked this up. Okay, this is something called scimitar sign. Can you see this prominent thing, and this is going towards this region? All right, so I told you the descending pulmonary artery will go like that. Okay, but the descending pulmonary artery is going to go away, and it's going to spread out and go towards this direction like this. This one is actually a vessel which is coming like this and curving towards this, right? So this is something called a scimitar sign. Okay, the scimitar sign is something what is seen in a partial anomalous pulmonary venous return. So there is an anomalous vein which is going to go into the systemic circulation. All right, so this is this. Can you see this? So anomalous pulmonary vein which is starting like that. All right, so that is called a scimitar sign. All right, this one, this is very easy. Okay, ASD, no. Okay, this one, tough. Okay, this is classical. Okay, boot shaped heart, tough. All right, this one, this is also a baby. I don't know if you will be ever see this. Okay, this is an Epstein's anomaly. All right, so this is called a box shaped heart. Okay, so Epstein is basically when you have that tricuspid valve is quite inferiorly located, so part of the atrium becomes ventricular type, so that is Epstein's anomaly. All right, it's a box shaped heart. And this, I don't know if anybody is seeing the abnormality. Right sided, very good, very good. Okay, that's a great pickup. Okay, that's a right sided aortic arch. All right, okay, this you shouldn't be missing. Okay, right sided arch, it's I wouldn't say so common, but you might fairly commonly seen this right sided aortic arch. Okay, it can be associated with other anomalies as well. And this, I don't know if it's projecting well. Okay, this is the coagulation of biota. If you can see, there is this curve which is there suddenly in the middle. Okay, that is coagulation of biota. All right, and if you zoom up and see here, you can see the inferior rib notching. Okay, this is the image, MR image, which is showing the constriction at this point. This is the descending thoracic. This is the ascending arch. Descending thoracic aorta is coming like that. Okay, this is an MR image. Okay, this is the constriction at this point. Okay, that's the inferior rib notching. Notching, you make sure you zoom a bit and see, then only you will be able to pick it up. Okay, this is actually an aortic aneurysm. Okay, so like some commonly we'll see it in little older people, like the aorta can be quite enlarged, it can look like this. Okay, sometimes it can, like sometimes you'll think, okay, there is superior mediastinal monitoring, something is sitting there. When you take the CT, you will see that just a dilated aorta. So this is an aneurysmally dilated. It's more than, it was around 3.7 or 4 centimeter almost it was. All right, and this, I think we are almost, there is a clue also actually, I think. Knee bag, okay. All right, very good. That's a pericardial. So this is the pericardial effusion. Okay, some money back sign of the pericardial effusion. All right, because the cardia, why does this happen is because the pericardium is getting attached at this, the root of these vessels. So when you have pleural effusion, the whole thing is going to like enlarge like that. Okay, and this part is going to like look like there's a purse string kind of thing, just constriction there. So that is a money bag appearance of pericardial effusion. This, again, something you should never miss. Pericardial effusion, pneumomediastinum. Yes, Ruth. Good. Okay. That's a pneumomediastinum. So why did I say it's a pneumomediastinum? So it's a sale. This is another sale sign. Okay, by the way. All right. So you can see can you see the border of this? So normally the heart should actually sit on diaphragm. And because the heart and the diaphragm are of similar density, you're not going to be able to see the border of the diaphragm. If you're seeing the diaphragm continuously, again, the inferior border of the heart is seen continuously along with separate from the diaphragm. Again, there is some air which is in between, and the pneumomediastinum can actually track up. It can go up into the neck. Okay, it can go along the vessels. You might be able to see it around the aortic knuckle. All these regions you will be able to see. All right, this one is an interesting one. These two cases, this and this, are two different cases. This one is fairly simple. Anybody has any idea what the right side one could be? And there's a pacemaker which is sitting there. It was recently put. Yes, this is a pneumopericardium. So it's same like the like the pericardial effusion. No? Inside the pericardial space, the air will be there. And this one, the right one, the heart is not there only. We are not seeing the heart. Patient has no heart. No. There's a chest tube. Are you seeing these tubes and all which are being put? See, always make sure you see the tubes in every X-ray, okay? Especially when you're in an emergency setting. Okay, this is pneumocardia, all right? So that is actually there's so much of air inside the heart, like you can barely see. I told you the attenuation is depending on what is inside it. The heart has blood. Blood is similar to like soft tissue or fluid, which will have similar density. If you have air inside, it's going to look more lucent. All right, that's all. I think, thank you. I think tomorrow we'll just go through CT, and we'll see like how to go about how to order a CT, like what all when do you order contrast, when do you not order the contrast, and then we'll also go over maybe some HRCT sections on how to look for ILD, just basic thing, how to identify an atelectasis, how to identify saying it's a consolidation, how to say if it's a mass. These basic things we'll go through. Okay, thank you.
Anyone has any further questions? You can either pull down the chat box or can ask now. You can come back tomorrow also with further doubts. This lecture will be uploaded soon in the website.
That's all. Okay. Okay. Have a good day. Bye then.
Thank you, guys.